Okay, sorry to keep bugging you.
Simmer down, nurses, simmer down, and medics.
So I want to talk about why do we have two devices sometimes, and what's the deal with the balloon pump and the Impella, and why, if we have ECMO and it's so great, why do we need all these other things? So initially in the cath lab or the OR or whatever, they'll think, oh, I just need just a little bit of support. So they'll put in a balloon pump to start with. And the balloon is just this thing. It goes in the femoral artery and up into the aortic arch. So it advances all the way to about here. And the way the balloon works is when it inflates, it pushes blood into the coronary arteries, so it increases myocardial oxygenation. And then when it quickly deflates, it deflates very, very fast. And as it deflates, it creates sort of a vacuum, and so it pulls blood. As it deflates just when the ventricle is ejecting, and so it pulls blood from the ventricle, and it decreases the workload of the LV. So it's only one-sided. It's just the left side that gets decreased myocardial workload. So for some patients, it's enough. For biventricular failure, it's frequently not enough. But they put it in the femoral artery, and it's not too big. There's a sheath that it goes into that's missing off of this one. But it's big enough that if you were to pull it out on someone who's heparinized, they're going to bleed. And you can't put an arterial cannula in the same hole and pull this out. So if they have a balloon to start with, they're going to leave it in with ECMO. They'll put the arterial cannula on the opposite side of the balloon, and they can put the venous cannula on the same side as the balloon. And I'll talk about the Impella, and then I'll tell you why they're good to leave in anyway. So in the cath lab, they'll put in an Impella a lot of times, and the Impella comes in different sizes. There's a 2.5, which is 2.5 liters. There's a CP, which is 3.5 liters. I don't know why they don't just call it a 3.5, but whatever. A CP, and then there's a 5 liter. So the Impella looks like this. It also goes into the femoral artery, but it goes all the way through the valve, the aortic valve, and sits in the ventricle like this. So this bend is right at the aortic valve. Blood is sucked from, it's also centrifugal, so blood is sucked into this part of the motor, goes through the lumen, and it comes out of this part. So it perfuses the coronary arteries very well, and it takes the blood out of the ventricle and goes to the body. But if it's 2.5 or 3.5 liters, that's barely an index of 1 or maybe 1.5 if you're lucky. So if they're in biventricular failure, it's also not enough flow. Sometimes it's enough that if you can unload the LV, then the poor suffering right side can pump to the left side, and then the Impella can flow. But it still isn't a good index with just 3.5 liters. But they'll leave them in as a vent. The heart can never recover if the ventricles don't decompress and remodel. The way the actin and myosin fibers of the myocardium interlock, if the heart stretch, it can't contract if the fibers don't come together. So the heart has to decompress and has to be small and remodel, otherwise the ventricle's never going to get better. So even with ECMO in, the balloon pump and the Impella will stay in because they're great to help decompress the ventricle. It's a vent, we call it. It vents the blood out of the LV, makes it smaller. The main problem you'll see with the Impella is V-tach, and it's because of suck down. It's not that the heart is arresting. If the heart is big and struggling when they put the Impella in, the ventricle is going to be big, so the Impella is going to be in farther. But now that we put ECMO in and we're taking blood out of the heart and putting the aortic blood somewhere else, there's not a lot of blood left in the heart. So now it's, instead of being this big, with the impella sitting here, now the ventricle's this big, and the impella is gonna be right next to the ventricle, and this is frequently tickles the wall of the ventricle or the septum. So they can be in VTAC. They're not coding, they're just getting irritated from this. So what the MCS nurse needs to do, sorry, I'll answer your question in 1 second. The impella can flow as high as, it has different levels. There's a P8 all the way to P1. So if it's P8 and it's spinning like crazy and pulling blood, it's gonna pull the ventricle into the motor. So it's either tickling here or it's tickling the motor where the motor is, because it's pulling blood in. So they just need to turn the P level down, and you need to give volume. You need to you need to increase the size of the LV so the impella isn't causing irritation. Sorry.
I've had time to think about it now, and it wasn't as funny as I was planning on it being, so we'll just bypass.
Oh, okay. Sorry, I didn't give you your time to shine. So I know we've had.
That was funny.
I didn't hear it. What?
I said, too bad life doesn't afford you those opportunities.
Well, most people have a filter, so they don't need that time.
So I know we've had some impella flights where the patients were in VTAC for quite a bit of the flight. The other thing that leads to that is the placement, the way the outside person places the impella. So if the impella is put in, but it's perfectly placed right here, where this is perfectly placed, this is a problem. Because if it's in, if this is all in where it's on the top side of the aorta, it gives the impella a lot of place to move. This region from here to here is called slack. And a lot of outside doctors forget to take the slack out, or they don't know to take the slack out. So if it's in and they're looking at it with echo and they're saying, oh no, the impella is perfectly placed, this sometimes isn't the issue. So what the MCS nurse needs to do is actually pull the impella from the groin, pull it out a little bit, because then if this part of the impella is on the lower curvature of the aorta, it can't slide in because it's against the bottom. So if you have a lot of VTAC, if you're on ECMO, or even just the impella, if you have a lot of VTAC, it needs to come out a little bit. Don't code the patient until you turn down the P level and until the MCS nurse checks the distance and maybe backs it out. The other thing with the impella is it locks, and this locking mechanism can frequently get loose, and so if it's loose, then the impella is going to slide in and out of the ventricle more. So that's the first thing to do with the impella to treat VTAC. And then with the balloon, it usually stays put. It's not a big deal. Any of these items, the ECMO cannulas, the balloon, the impella, if it's in the groin, the patients cannot sit up. We've had, can I talk bad about some other flight teams? Where somebody brought
Just don't name them.
I won't name it. They brought an impella patient on the stretcher sitting straight up in the bed on the stretcher. And that is bad because there is this very stiff sheath that's in their femoral artery, and so they're sitting up like this and yanking on the insertion site on the artery, and the patient had a quite significant retroperitoneal bleed because of just the way they're sitting, so they cannot sit up.
So they have to be completely supine, or can they?
They can be tilted, they just can't
They can't
bend. Yeah, they cannot bend. Yeah. So they may have a balloon, they may have an impella. I don't think there's anything else that they put in there. And then the other thing I want to talk about is heparin. So in the OR, to have heart surgery, they have to be heparinized. The measure they'll use in the operating room is an ACT, activated clotting time. And in the operating room for the bypass, the ACT has to be greater than 400, and that's basically 400 seconds. So imagine putting blood in a petri dish and waiting for 400 seconds for it to clot. That's a long time. Normal ACT for us is like 80 to 120, 100 to 120, something like that. So about 2 minutes for our blood to clot. So they give heparin until the ACT is above 400. If we're picking up a patient from the OR, if I'm picking up a patient from the OR and I hear that their ACT is 350 and they're on a heparin drip, I will tell you we are not transporting with the heparin drip. We're going to turn it off. If I hear that their PTT is greater than 150, we're not transporting with the heparin drip. In our ICU, we don't trend ACTs, we trend PTTs, and our goal PTT for an ECMO patient is at the beginning when they're bleeding, like say post-op, at the beginning our goal is 40 to 60, and then as they are getting better, then our goal is maybe going to be 60 to 80, but we never go higher than that. We've had patients from outside facilities that, because the perfusionists are running the ECMO, and they're used to having ACTs in the 400s, they'll run their ACTs on ECMO in the 400s. We've had a lot of head bleeds and herniations because of a high ACT. So don't transport heparin if your PTT is higher than, I would say, higher than 100. Don't transport the heparin. We'll just turn it off. You don't need it. It has a long half-life, especially low flow to their liver, so it's going to last even longer.
Do you actively try to correct it
If they're
it's
actively
high?
bleeding, yes, we will. Yeah, we don't give factor 7 or anything like that, but we'll do FFP and cryo.
Okay.
Yeah, the factor 7 is a risk of clotting the oxygenator, so we don't want to do that.
No,
But
that's
the
only if they're bleeding.
FFP, cryo, and our platelet goal is usually around 100
Okay.
if they're bleeding, but we'll let it drift down if they're not bleeding. And then let's see, EKG, you'll see everything under the sun. You'll see VTAC, VFib, something that looks like a STEMI, something that looks like an N-STEMI. The cannulas irritate the conduction sometimes. The heart's sick. We don't care what the EKG is, as long as they're contracting, and as long as they're not in VFib, VTAC, we will, if it's true VFib, VTAC, not just as the Impella or suck down or something, we will shock them out of it. But if they're in VFib or VTAC, the first thing we'll do is troubleshoot the machinery, make sure that there's no suck down, make sure it's not irritating them, and then after a while, a minute or so, then we'll cardiovert them. And we always, I know it sounds counterintuitive, but if they're in VTAC, we will synchronize cardiovert them when they're on ECMO. It seems to work a little bit better. What did I forget? What questions?
What about asystole?
We don't want asystole. They have to.
You might see it though.
They did.
You might see it.
You'll see it, but we don't want it. So we've had.
Normally, I know.
Yeah, we have had. I was telling you about we didn't want hypertension either. Hypertension above 85, and we've had patients who were hypertensive, and so the epi was turned off. And you look back at their waveforms, and they have a CVP that looks like this, and then a CVP that looks like this, and then a CVP that looks like that. They have to be contracting, so even a little bit of epi, 0.02 or something is necessary.
To fix asystole, you guys ever pace?
Yes.
Okay.
Yep. If they're coming from surgery, they'll already usually have epicardial wires. If they're coming from the cath lab, we'll have them put in a transvenous pacer.
Are you gonna go through any troubleshooting the balloon pump?
We don't care about the balloon as long as it's opening and closing. The waveforms look totally different on ECMO. It's not the balloon cannot support the heart as much as ECMO can. There's no reduction in afterload because you already have it from ECMO. It's basically there to vent, and so the waveforms are all jacked up. There's nothing to look at.
Can you just give a basic rundown of like the helium and
I can.
and how to troubleshoot, like if the battery dies or
That's what
inflating
the
it and
CVS
deflating it.
nurses
So the,
They just turned to the CD nurse.
so
Just for the video's sake.
yeah, the way the balloon works, you have to have an EKG and or an art line. You have to have something to trigger the balloon to work. So you're gonna have the pressure plugged in here. You're going to have the EKG plugged into here. And then the helium plugs into here. So when you're transporting, you have these three things. And helium is the gas of choice because it's really light and moves very quickly. So as it's shuttling back and forth between this really small lumen to inflate the balloon, there's no other gas that can make the balloon inflate and deflate as fast as the heartbeat, 80 or 120 or whatever the heart rate is. So helium is the what the company made it to be, and we will make the balloon inflate and deflate based off of the EKG. The blood pressure is hard. It can also, like in a normal non-ECMO patient, the balloon can trigger off of an art line, but it has to have a normal waveform like this. The balloon can't trigger off of an art line like this. So we'll just trigger off the EKG. Mostly with the balloon, it's a big pain because the machine's big and the cables aren't that long. You'll see in the training, the cables aren't that long, so as you're loading in and out of the aircraft, sometimes you have to unplug it. But the patient will not die immediately if the balloon is unplugged. You have some time. They will die immediately if you turn off the ECMO or decannulate the ECMO patient, the ECMO cannulas. So it's better to unplug the balloon, leave this on the ground for a minute, get the patient loaded, and then put the balloon up in the aircraft. But the balloon doesn't support them enough. The Impella does support, it helps vent. You can't unplug the Impella. So, but the console is much smaller, so it's easier to move. And the tubing is much longer. So it's easier to move them around.
Does that even apply for if they're just a balloon pump patient, or you can still unplug it and
You
load it
can,
and then
yeah,
plug it back
they're
in?
not gonna immediately die.
When we go up, like if we are in the 145 where it's non-pressurized cabin and we go up to an altitude, because that's helium and it's being fed from a compressed source, how is that gonna affect the size of the balloon?
It does,
As it
and-
inflates and deflates?
And the nurses know, usually at altitude, like say it's a 40 cc balloon, they'll take out 4 cc's, so they'll run at 36, and then as soon as they land, the machine will actually alarm. When you're at altitude, the machine will alarm high pressure, so they'll take out the air, and then when you land, it'll alarm low pressure, so they'll put it back in.
And then as far as, because we're more concerned with the transport side of things, as far as equipment on board, like enough oxygen and stuff like that, is there any type of a standard that we need to?
Yeah, and I haven't talked about ventilators yet, thank you, I knew there was one more thing I was supposed to say, y'all are sick of hearing me talk, but when they're on ECMO, and especially VV ECMO, we pick these patients up with ARDS or burns or something, and they're on wicked high vent settings, just, stupid bi-level things or something terrible. And then once we put them on VV ECMO, we're like, okay, 10 over 10, and 40%, you're like, what, no. We don't actually care on ECMO patients what their tidal volumes are. We do want them to ventilate a little bit, but it doesn't matter because they're not oxygenating, and it's better, especially on VV patients, it's better to not stretch their alveoli. We need to let the alveoli heal. So if you pick them up a crazy amount, and we'll turn it down to as low as we can get it. Because their heart still is pumping, you're gonna get some deoxygenated blood going through, or less oxygenated blood going through normal circulation. So our SpO2, we're okay with saturations usually like in the high 80s. We don't have to shoot for A+. We'll go for B+ is fine. But you're gonna get mixing of blood from the cannula, and then lesser oxidated blood going through normal circulation, and that's just what you're gonna get. So some patients, we might have to have a little higher vent settings if their sats are in the 60s, because they're still doing some lung function. but for the most part, our goal is 10/10 and ARDS protocol. So instead of a normal 6 to 10 mils per kg, 6 to 10 mils per kg, I did that wrong. We're doing like 3 to 6 mils per kg for tire volumes. Is that right, Stace?
Yeah.
6 is the magic number there.
Yeah, we'll just remember
Three.
6.
3 is, yeah.
3 is the magic number. Yeah.
6 is in
Yeah.
both.
6 is high. So, and then just, your PIP and PEEP is 10/10 or less if you can have it. And then the FiO2, you want it as low as can be. In the ICU, sometimes we'll run them on 21%.
What are some of the more common combinations of the devices that you see, or I know it can be varied.
Femoral ECMO with an Impella is probably one of our more common, and then ECMO with a balloon coming out of surgery is probably the second most. But if it's a surgical patient, because you have to have fluoro to put the Impella in, and most ORs aren't set up for that, they'll put the balloon in first, and then if the balloon's not enough, they'll do central ECMO. Cath lab, they have fluoro readily available, so they'll try the Impella first, and then they'll do femoral cannulation for ECMO.
You have balloon and an Impella?
I used to say no, but we've had 2 recently.
I think
So,
I've seen that before,
yeah.
but it doesn't make any sense.
Yeah, it doesn't make any sense to have a balloon and an Impella. So they put the balloon in first,
That's cool.
so the balloon's sitting right here, and now you have an Impella in the same. And you would think that makes no sense, but we've seen it now, and
Just
Is
more
it because of
decompression.
Is it because of the pulsatility that the balloon pump provides, or?
they put the balloon in first. The balloon costs about $500. The Impella is $30,000. So they'll put the balloon in first, and then they'll say, oh, that's not enough support, and then they'll put the Impella in.
And so you leave the balloon in.
Yeah, you leave the, and usually it's in opposite femoral arteries, but obviously the same aorta.
Do the patients have to do a down payment at that time?
Yeah.
Are they leaving it just because they're so anticoagulated?
Yeah, yeah, they'll leave the balloon in because they're anticoagulated, and if the balloon's in, if they take it out, they'll arrest before they they can get the Impella in, and they'll be just gushing blood out of the hole. So they'll just do one on each side. Yeah, I used to tell people, oh, well, they would never do balloon and Impella, but yeah, they do.
Well, thank you.
Thank you, guys. I'm doing, if you dare to hear me yammer on more, there's an ECMO class December 10th, is that the second Tuesday?